don't know if this is necessarily worldwide, but in the NHS, we often talk about the level of care that we're providing in levels 1, 2, and 3. Level 1 just being on a ward where you can be admitted as an inpatient, stay there, receive IV antibiotics, oxygen from the wall, that sort of thing. And that's kind of the baseline of what we do in hospital. And up until 40 years ago, that's probably all they would have been able to provide in hospital, was the kind of level of care that you would get in a ward. And then some maverick anaesthetists and cardiologists started coming together and producing other areas which have slightly more monitoring, slightly more fancy technology, and slightly more intensive input. So I've put level 1 and 0.5-ish because they're technically not critical care areas, but they have some of these increased levels of monitoring and increased intervention levels that you might find in a critical care area. So coronary care units are a perfect example. You can find yourself getting cardiac monitoring there. You can end up getting invasive central access on a critical care unit, such as a central line. And you can also get things like dobutamine or dopamine for people that have heart failure, which are both inotropic support, and they can have external pacing, and also CPAP is another important intervention. So they can have lots of different interventions there, but it's not quite the level of a full HTU. Respiratory ward can often provide specific respiratory support up to the level of NIV and sometimes high flow nasal oxygen. And that, again, not quite a full HTU level of care. And the reason for that is nursing ratios. The nursing staff make up the vast majority of what makes critical care so special. The average ward nurse in the NHS doesn't have the same level of medical knowledge, and they don't have the same level of organ support knowledge. And they also have to look after far more patients as a very different skill set. A lot of the ward nurses in the NHS are concerned mostly with discharging patients and making sure their social care is arranged, whereas in a critical care area, they're far more focused on the medical care of the patient. Because I think everywhere, I think in a critical care area, you're recognized as being unwell, and that's quite important as well. It's just the recognition of someone moving up a level of care, is just recognizing actually this person's unwell and they need a good bit of input. So level 2 care is HTU and can provide almost everything. They can provide organ support. Single organ support is generally what gets done in level 2 care. So whether that's cardiovascular support with inotropes and vasopressors, or respiratory support up to the level of high flow nasal oxygen, NIV, BiPAP. I suppose the main thing that they can't do in HTU is mechanical intubation and ventilation, which is firmly within the realm of intensive care. Intensive care is, as I said, for people that are ventilated, requiring infusions of anesthetic or sedating drugs. You'll often find people with multiple organ failures, people who require renal replacement therapy, they end up going to ICU.